This is Finn Voices on the Healthcare Now Radio, where we highlight and amplify the voices at the forefront of health innovation that improves people's lives. Join us for an inside look at the changemakers driving conversation and answering the most important questions in healthcare today. Thanks for joining us.
Hello, everyone, and welcome back to Finn Voices, a show where we amplify the voices of healthcare innovators. I am your host, Carrie Young, in the Twin Cities, where I'm a partner at Finn Partners, and I work with leaders across the health ecosystem. Today, I am so pleased to introduce my guest, Dr. Ashwini Sharan, Chief Medical Officer for the Neuromodulation Operating Unit at Medtronic. Dr. Sharan plays a key role in shaping the strategic direction of Medtronic's innovation and clinical evidence plans, helps guide physicians, society, and education engagements, serves as a medical advisor to the business, and interacts with the medical community to identify current and future business opportunities to address unmet medical needs. Dr. Sharan has 25 years of experience and is one of the top neurosurgeons in the United States. He is highly sought after in terms of both his practice and thought leadership in the neurological space. And welcome, Dr. Sharan.
Thank you for having me here, Carrie. I look forward to sharing our thoughts together.
Well, I'd like to start at the beginning, which seems like a good place to start. Tell us about your background and why you chose neurosurgery.
I'm going to amend that a tiny bit because I was sort of nudged into it by my father. You know, I actually thought I was going to be a computer programmer. I read Wired magazine, and there's this famous magazine that's actually right in my office, and I keep it there as a reminder, where it's about Bruce Sterling and, you know, about being a futurist. And my father in that time in the late 70s wasn't sure if this computer thing was going to stick. So he's like, no, you need to do a profession that everybody knows and loves and will always need. So he sort of suggested that I become a doctor. And somewhere in my mind, I had that Wired picture in my head. And I wanted to be a doctor that actually implants chips in the body. And somehow the energy of the universe was working in my favor. And so that's where I am today. I actually did 2 fellowships in neurosurgery. So I did med school followed by neurosurgery. And what I fell in love with was this idea of understanding what causes pain in the body. And the reason I did 2 fellowships is there's a spinal component and there's a electrophysiological component, the way the nerves work, right? So there's a mechanical problem, which you need a construction for, and there's an electrical problem. And so as a neurosurgeon, we actually can cover both diseases and are both, let's say, manifestations of a problem. And so I had that opportunity, and I said, I want to have a toolkit that not only, you know, can I change the body in one way, but change it in multiple ways, because that's where the convergence was.
We're going to talk about that toolkit in a minute. I want to hear more about that. But I'm interested in, you know, did a little bit of homework, saw that you spent more than 20 years in a hospital setting, and then made the leap to Medtronic. So tell us about that. What brought you to Medtronic?
A lot of it was luck and fortune. Let's put it that way. I'm just grateful that, again, going back to the energy of the universe working for me. So in the post-COVID world, you know, when people were doing a little bit more from Zoom and at home, I became a little bit more administrative in my own department because I had been there for 20 years. So I became involved in the operations. And I sort of had this idea that you can make a big impact if you can empower teams to do more, you know? And so at that time in my life, I had already done 8,000 operations. And so the idea was, and I love it. I love taking care of people with problems that can't be solved and solving it. And the idea was, then how do I make a systems change? How do I do more impact? And the transition to Medtronic was hard because I gave up the intimacy of daily patient care with people. But when Medtronic approached me looking for chief medical officers, you know, they were interviewing other people. But from my perspective, I looked at this company as a place where they're engineering the extraordinary. They have mechanical engineers, electrical engineers, they have neuroscientists. I mean, they have world-class passionate people in this organization, expertise in cardiac and diabetes, 5 divisions in the neurosciences. So this multidisciplinary team is like having your own, you know, Formula One team where I'm the driver and I have all these people making sure that every part is perfect. And then the final kicker when I came to Medtronic is the mission of this company is use technology to alleviate pain, restore health, and extend life. And it was like they were calling me, when that happened. So I don't want to be so
That's right.
emotional about it, but it was a great fit.
Yeah, and it's a company that lives its mission. So I can appreciate that. I want to drill down a little bit to talk about chronic pain, the concept of chronic pain. I want to understand the scope of the problem in the U.S. How big of a problem is it? And so tell us more about
So chronic pain is
tell us more
awful,
about that.
right? Because it's a little bit of a maladaptive problem. Everybody has pain and everybody deals with it very differently, and it's very personal. And just to put it into numbers, 1 in 5 Americans suffer from chronic pain. Almost everybody has a family member or a friend that has gone through it and is going through it. By population, you can say that 7% of the people have disabling pain, and the word disabling referring to restriction in your activities of daily living, meaning that do you have trouble walking up and down the steps? Do you have trouble getting out of bed? I mean, there's so many components of this problem. And there's a second part of the problem. So it's not just what chronic pain is the healthcare system it's a maze. So how do patients who have this problem even know where to end up and what therapies and options are available? What type of doctors, nurses, nurse practitioners, PAs, who do they go to navigate this maze? Because it is that. So it's a huge problem.
Right. So what are the most common treatments for chronic pain?
Yeah.
There are lots.
So,
So talk to us about
chronic
that.
pain has to be focused at hopefully trying to find a diagnosis. Now, the diagnosis is aimed at trying to figure out what was the inciting cause, right? And if it's spinal pain specifically, you might treat it with physical therapy and anti-inflammatory medications. And I double down on anti-inflammatory medications because almost every problem causes some kind of inflammation in your body, and it's amazing at how often, and it's not a one-time thing. If it's chronic, that means the inflammation is there every single day. So you can't just take the Advil, Motrin, ibuprofen one day. You have to take it recurrently because you're trying to smolder a fire, right? And then if those things don't work, the combination of therapy to rehabilitate the body, there's different interventional procedures. Sometimes you do injections, and most common injection is a steroid, right? Again, to reduce the inflammation in the joint or in the muscle or around the nerves. And then, of course, there's even more and more less invasive procedures. Neural stimulation, something that we can talk about. You can infuse drugs into the body. So there's 100 different ways to treat chronic pain. And then I don't want to also eliminate the fact that chronic pain has a psychological component, right? It wears down on you. It wears down on your spirit, right? And even when people develop, imagine this, Carrie, that every day you're waking up and it's not better. That's really an anxiety-provoking situation, and anxiety acts like an amplifier for the pain too, because of the way the brain circuit works. And so at some point you might even have to treat the brain as well as the body, right? Because they're one.
Yeah, gosh, that feels close to home. I think most of us know someone who suffers from chronic pain. So the way you describe that feels familiar. So, but I am wondering, with so many treatment options, right? There's medication, there's physical therapy, occupational therapy, interventional procedures. Why are there still unmet patient needs when it comes to treating chronic pain?
So I'll break it down into two things. One is I think physicians and the healthcare system is designed, I call it the 80-20 rule. If you fall in a common problem, then the treatments are very clear cut and people have training in it. Now go back to my training. I trained both with structural spine surgery and functional neurosurgery, which was about the electronics, right? So I'm cross-trained. Now, let's say the patient goes through the maze and ends up in the structural spine surgeon's office. They may not know about the electrical options, and vice versa is also true. Let's say you end up in the electrical surgeon's office. You might not know about the less invasive structural fixes. So one is the medical community and education wasn't designed to really be holistic, number one. And then number two, for a number of years, people became a little bit obsessed about prescribing narcotics and opioids. And then later we found out that there were problems with it also. And so I think for a decade, we probably didn't do the research and the awareness. And so I think we're playing catch up, but I think that's changing, hopefully. So I think it's a multifactorial problem, actually.
And help us understand the pain scale. I mean, we've all been to the doctor, we've rated our pain 1 to 10, right, in the ED or wherever. What are the shortcomings of that
Yeah,
type
the
of
pain
system?
scale. It's been around for such a long time, and just to describe it for everybody who's listening, it's basically a scale, and the patient sort of guesses where they are. Or you can have smiley faces, or some people number it and call it the numerical rating system from 0 to 10. And that scale is so inaccurate, right? Because the only person who can really object, it's not a thermometer. You can't actually use it to measure. And so as person sort of gauging on their own how they feel. And then it's not continuous because it only is a snapshot of how you feel at that moment. And your condition fluctuates depending on your activity and your mood. And so it's something that needs to be modernized for sure. People are shifting to different type of measures. There's something called Promise 29, patient reported outcome measurement. The NIH spent a lot of money validating these new scales, and the Promise 29 specifically is trying to break pain into 7 domains. So can the patient rate their physical function, fatigue, pain interference, anxiety, depression, ability to participate, and sleep? So let's look at what pain is doing in your body on so many areas, because you can quantify some of these other things so much better, right? So I think that is going to be tomorrow's shift with some objective measures from the body itself. So we're going to have what's called a composite scoring that will develop. And I think the people and the world and even internationally, people are shifting to these different measures.
Well, and it's more holistic, like you just said. I mean, right? So we're going to shift gears a little bit and dial in because I'm so interested in this technology. I want to hear more about spinal cord stimulation for pain relief, what it is. So tell our audience what it is and how does it work?
Okay, that's awesome. So spinal cord stimulation has been around for about 40 years now. And fundamentally, it's you thread a small wire that sits on top of your spinal cord and is connected to a battery. So I describe it to the patients as almost like a pacemaker. Instead of wiring the heart, which is what most people are familiar with, you're sending electrical impulses to the spinal cord. The battery is like the size of a watch face. Today's technology, we're already probably on generation 4 and 5, and it sends different patterns to the spinal cord. And by sending those patterns, now fundamentally, just to take one other step in parallel, for you to take pain back and perceive it, the signal from your hands, your legs, your broken knee, or your hurt spine, the conduit for that information is through the spinal cord and has to get to the brain. So what you're trying to do is interrupt or block those signals or mix them up. I mean, that's the simple way. There's a lot more biology that goes into that science. But it's basically a reversible therapy. You can test the therapy. There's a lot of studies. In medicine, we call these things randomized control studies. And there's randomized control data that supports its use now. So it's proven and effective. It's amazing that more people don't know about it.
Am I right? Did Medtronic develop the first spinal cord stimulator? Is that right?
No, thank you for giving us credit. That's absolutely accurate. Our company invented the pacemaker, and it's even more romantic than that. Our founder, Earl Bakken, he had the vision that, once you started stimulating the heart and sensing signals from the heart, right? Today we have defibrillators. He actually had a 50-year vision that it would actually then use the same technology to help the brain and same technology to help the spinal cord. And I think he did that in the 1970s. So yeah, Medtronic is the first company.
That's amazing. I have a quick follow-up to that. But before we do that, if you are just tuning in, you're listening to Finn Voices on Healthcare Now Radio. I'm Carrie Young, and today we're speaking with Dr. Ashwini Sharan, Chief Medical Officer for Neuromodulation Operating Unit at Medtronic. I've heard about MRI capability. Is that a thing with SCS? Is that a concern? Can you get an MRI if you have a spinal cord stimulator?
Yeah, thank you for this question too, because there is a historical problem and then what modern technology has fixed. So before, an MRI is a gigantic, strong magnetic field. And if somebody with a pacemaker went in it, there was concerns, not because the wire would move, but it would generate electrical currents inside the wire, not from the battery, from the MRI machine. Medtronic re-engineered its platform because it knew when MRI was developing, and MRIs probably started happening effectively in the 80s and became popular by the late 90s. And today, the numbers are gigantic. It's probably the best, most precise diagnostic test there is to diagnose what's happening inside the brain and the spinal cord and the body. So we re-engineered the entire platform. We created what's called shielding in the wires. We created filtered feed throughs in the battery. So I don't want to get so technical because I become nerdy about it. But today, our systems are, we call them MR conditional because they have a massive tolerance to be able to get an MRI. And our system is the most comprehensive MR compatible system there is.
Awesome. That's a game changer. But I also know that not everyone can get relief through SCS. So talk to us about some typical patients who will benefit from this therapy.
Yeah, the three or four most common procedures, and the way we like to talk about it is what on label and what has been proven with data. And the most common case is people who've had spinal surgery and the pain persists. It used to be called failed back surgery syndrome. This is now reclassified for people who hear this in the future. It's going to be called post-spinal pain syndrome after spinal surgery because it's more descriptively inaccurate. This idea that failed back surgery, sort of said that it almost laid blame, and maybe it weren't done right, but that may not be true. And I just want to clarify that for a second. See, pain could have a structural component and a nerve component. And so the spine surgery may perhaps fix the structural component, but didn't fix the electrical component because you can't like cut a bad nerve and plug it back in, So the new term is called post-spinal pain syndrome. There are people who have what's called complex regional pain syndrome. People have degenerative disc disease, radiculopathy, the other causes of spinal pain that don't respond to spinal surgery. Recently, there's great evidence that has come out for diabetic peripheral neuropathy. So a lot of problems that have a nerve aspect to the pain, can be trialed and then tested and then, of course, implanted with spinal cord stimulation.
And let's just talk for a minute about DPN, diabetic peripheral neuropathy, right? So that can be, well, first of all, lots of folks have diabetes, right? And I imagine, in our population, and lots of folks probably suffer from that. Is that a relatively new, has SCS always treated DPN, or is that relatively new?
I think our understanding of diabetic peripheral neuropathy has improved, with science getting better over time. People had tried it on and off, and data started emerging on the treatment probably in 2014 and 2015. That were the first two studies that Medtronic worked with investigators in Europe, and then eventually got FDA approval in recent times. So there's a lot more buzz about it inside the United States. Just if you would allow me to take a step back and just be an advocate, diabetes, it's a bad disease because that disease can affect your heart, your eyesight, your kidneys, but of course also can affect your nerves and the blood flow in your legs. And so these patients can't walk, they have burning pain in their legs, they get ulcers because they can't feel a thumbtack, and then all of a sudden it gets infected, right? So, and then over time, it causes atrophy of the spinal cord and atrophy of the brain. So this thing is affecting your nervous system. And so the fact that you can reduce the pain so somebody can walk predictably, from this problem, the diabetic peripheral neuropathy pain, it's huge because how else can you combat? Of course, you have to get control of your glucose and your hemoglobin A1C, but then you got to move and get your body rehabilitated.
Yeah, well, that falls in game changer territory as well. So, and I knew there was recent FDA approval. Is that right? I think in the last year.
It is a recent, yeah. We're proud of the team for bringing that through from Europe and taking it over the finish line.
Yeah, for patients. So I know that your neuromodulation business encompasses more than just the technologies that treat pain. For example, what do you have for movement disorders? And I'll get personal for a minute. My dad has Parkinson's, and I was talking to him about deep brain stimulation. He said they don't do that anymore. And I thought, "Well, I think that's right." So I would love to hear from you. Tell us more about that.
Yeah, so deep brain stimulation for Parkinson's disease has been FDA approved since 2001, and I think we have over 150,000 patients implanted around the world. So it's definitely not new. I think we're probably on generation 3 and 4 of the therapy. I'd like to tell you like a few things about it. When I first trained how to do it in my fellowship at the Cleveland Clinic, we used to take 6 to 8 hours to do the surgery. And today, just to give you some sense, just because the technology has gotten so much better, we can do the operation in about 2 hours. So there's so many different improvements in the way the electrodes are designed, what the battery can do. The technology platforms of the future will even sense what's happening inside the brain, and then you can actually personalize the therapy based. See, Parkinson's is not a static disease, right? Sometimes you tremor, sometimes you don't, sometimes you're stiff, sometimes you're not, right? Sometimes you freeze. So there's so many symptoms that vary. How does the therapy adjust itself? And so that's the kind of stuff that we're focused on now. So it's not just what we did, is what we can do in the future.
Yeah, I'm real fascinated about that and what the future holds in that regard. This position must be challenging and interesting, and I imagine you're passionate about it. I'm wondering what excites you in your field when you think about what's next? What gets you out of bed in the morning?
How much time do you have? But it's so first of all, we're in a company where we can come up with an idea and I can find 3 to 5 experts who can help me dig into the how, when, and why kind of thing, right? And so we can take crazy ideas and bring them in a very systematic manner because that's what engineers do. They can engineer the extraordinary, build the big, right? And so our platforms now have changed in the sense that, so what was next after stimulation? Just for the audience sake, when we used to set the stimulation parameters, we could change the frequency, pulse width, and amplitude, meaning the strength of the signal. And then that was set. So it's like taking a medication and being dosed, continuously. But you don't need it always, right? Like you saw in Parkinson's and pain, you may need more or less. You may have side effects, like if you take too much drug or you screw up the timing, you'll have side effects. And so we have been engineering in our platforms for deep brain stimulation and spinal cord stimulation the ability to sense. The cardiac people, the fact that we had competency inside the company to do that, so we can actually sense from the brain and sense from the spinal cord and then adjust the stimulation parameters. And this is what all our next generation platforms will be doing in the future. Right now, we're testing it out and we'll take it through FDA approval process to prove the safety and efficacy. But I just want to share with you why that's so crazy. The heart, think of it as a gigantic noise inside the body. So if I had a microphone inside your body, you'd hear the boom, 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 boom. The signals on the spinal cord in the brain are 1,000 times smaller. It's like being able to resolve the whisper in a stadium, of the person sitting next to you when the fans are screaming. Today, electrical technology can do that. And we can filter out all the noise and understand the recordings of the brain and spinal cord. So we're going to unlock the way the data is being transmitted in the body, right? How's the data from your walking, from your gait, bladder, blood pressure control, medication dosing? All this is tomorrow's frontier. So we can personalize the level of stimulation to that. And of course, I'm talking about the future right now, just to be clear, but this is what we're unlocking. Yeah.
Yeah. And there's a benefit there for patients, I imagine. It's significant.
It's gonna, but and of course, the last part of it is then you're collecting, like I told you, the Promise 29 was the 7 domains of pain that the patient experiences. And then we're going to couple it with the internal sensor information, right? So you're actually having real-time instruments inside the body. I don't want to call them instruments, otherwise I'm not sure how people feel about that. That's not a good visual. But you're going to have real life sensors inside the body that are going to be able to take those two things and then adjust it to your needs without you worrying about it, right? You don't go in every day and say, oh, let me reset the thermostat today. I mean, you could. We can allow the adjustability, but it sort of automatically does it exactly at the temperature that you want.
So we talked about the healthcare system being a maze, and indeed it is, because I have participated in that. If a patient wants more information, or say they're suffering from chronic pain and they want to take the next step, possibly talk to a specialist, what would they do next?
Yeah, no, I'm really glad that you're bringing this back up, Carrie, because it really gets me sad that it's the system is so complicated and people don't even know what's out there and they don't know how to get there, right? And so there's no doubt that first of all, there are actually people who are medical advocates today. You can actually research and Google, how do I find my own medical advocate? And there are people who are professionally doing this, doctors, nurses, PAs, to help patients navigate, almost like a personal navigator, your own concierge, how to get through that. Second is you have to push your physicians. People are so time constrained. Your visit might be 10 minutes, 15 minutes, and you're supposed to be out the door, but you didn't get to address. So you have to go prepared to these office visits, knowing what are those goals that you need. So this way, even at the end of the visit, every doctor and healthcare provider will say, did I answer all your questions? Or do you have any more questions? Or you should say, wait, I have one question. So you need to be prepared to know, because you have to be your own advocate, right? And then secondly, if you have chronic pain, there are some great societies out there. There's one called the North American Neuromodulation Society. So if you want sort of an unbiased, independent system, they have a physician finder. You can use that. And of course, you can come to the Medtronic website, and we have plenty of patient resources as well. So you can find a provider in your area that has that ability. And maybe the last one I'll tell you is many new things usually start at the university and the larger centers. And everybody doesn't want to make the drive, but in the post-COVID world, a lot more doctors, now I think you have to do it within state, but they're doing televisits. So you can even do a televisit and at least get an idea. Are you a candidate? And then you might have to go in for a real in-visit before you do something, but even those opportunities are there. So there's no reason in today's great information age that patients shouldn't get to the right goal.
Well, Dr. Sharan, thank you so much for being with us today. I mean, I love that conversation. And to our listeners, thank you for listening to Fin Voices, a show where we amplify the voices of healthcare innovators. I am Carrie Young with Fin Partners, and I'll see you next time.
Fin Voices is brought to you by Fin Partners, a global marketing and communications agency working across industries and services. Whether inside our walls or on the front lines of health transformation, we stand together to create meaningful and measurable impact in the world around us. Learn more at finpartners.com and follow us on Twitter @FinPartners.